welcome everybody to the first Scale Neonatology meeting of 2026. It's great to see so many people registered and so many people joined us already. Some familiar names and not faces. You can show your faces later for the photo, but familiar names, but also great to see some new names on there. So for those of you who are new to Scale, Scale is a program for strengthening health workforce capacity through global learning. It's a program, a partnership between the UK and Uganda, supported by West Yorkshire and Harrogate in the UK, NHS England, and then also Ministry of Health here in Uganda. And we have some centres of excellence here in Uganda, and also with support from Uganda UK Health Alliance as well. So we have a number of centres of clinical excellence for scale neonatology. There's different scales. There's for different areas of speciality, but ours today is neonatology. So we are really privileged today to have a team from one of our newborn centres of excellence. That's Lira Regional Referral Hospital. So we have got Dr. Florence Oyella, who is an associate consultant pediatrician at Lira Regional Referral Hospital, and she'll be joined by Moris Sekituku, who is one of our junior house officers. And we will also have a presentation from Raza Ahmad, who is a specialist pediatrician in West Yorkshire NHS Foundation. So the topic we have chosen today is neonatal pneumonia. We tried over the last few years to pick different projects, so things are getting a little bit more specialized, a little bit more interesting. So we will start, I think, with a presentation from Dr. Raza Ahmad today. And after that, we'll have time for any questions for him. We'll follow that with a presentation from the team at Lira Regional Referral Hospital and any questions for them. And then we will open up the floor for discussion. As the presentations are proceeding, kindly keep your microphones on mute so as not to disturb the presenters. And if you have any questions, do feel free to put them in the chat. And myself, Dr. Kath Harrison, I think, has also joined us online as well. We will do our best to answer those questions in the chat and maybe open some of them up for discussion as we move through. So with all that said, once again, anyone who's joined us on the way, welcome to the Scale Neonatology Clinical Grand Round, the first one of 2026. And I hand over to you, Raza, to take us through the first presentation. So please go ahead.
Good afternoon, everyone. I first introduced myself. My name is Dr. Raza. I'm one of the registrars working in Airedale General Hospital. So basically, I work in a smaller unit, in a special care baby unit. But obviously, we get these cases and we get in connection with the bigger units, LGI and other people around and in managing this stuff. So I'm just going to present a case of neonatal pneumonia that we recently had in our department. This baby ER was born in Airedale General Hospital in the neonatal unit. Its baby is a female infant, was born at 41 plus 3 weeks of gestation with a birth weight of 4.29 kgs. The baby was born long labor with a prolonged second stage of labor. There was a prolonged rupture of membrane for more than 36 hours. Initially, no problems during the pregnancy. It was midwife-led antenatal care. And at the time of the delivery, we were actually contacted around 5 minutes of life because initially it was more midwife-led delivery. Baby cried. So we were told the APGARs initially were 9 at 1 minute. So baby had a very good cry and then suddenly stopped crying and turned more blue with lack of respiratory effort at that time. So we arrived around 5 minutes of life. At that time, baby required a little bit of PEEP with inflation breaths, took 2 sets of inflation breaths, and then we continued with ventilation breaths. Baby was persistently requiring more oxygen. So that was transferred to our neonatal unit. So initial problems for the baby was increased work of breathing and low oxygen saturations. Based on the antenatal risk factors. There was a risk factor of congenital pneumonia as well. So I can tell you a little bit about the initial presentation first. So um, because the baby was on a PEEP with continuous ventilation breaths and was requiring around 70 to 80% of FiO2 initially, but gradually we weaned off oxygen slowly and baby started having its own respiratory effort. It was a good sized baby post-term. So when we moved the baby to our neonatal unit, we first started the baby on a high flow settings. We started with 2 liters per kg, initially around 6, started on 6 liter, but gradually increased because baby was good size, but it was really requiring a lot more oxygen than we were expecting, around 50 to 60% of FiO2. And we later on decided the baby has to be intubated. There was continuous tachypnea and tachycardia with the respiratory rate ranging from 70 to 80 per minute. Heart rate was around 130 to 150. We checked the pre and post ductal saturations. They were normal, equal. There was no difference in the pre and post ductal saturations. We got the baby intubated at that time and started on ventilator settings. There was the only risk factor for sepsis in this case was a prolonged rupture of membranes. Though there was no maternal temperatures, mom didn't receive any antibiotics antenatally. And around later on, because of the baby was transferred on ventilator, the baby was later on transferred in LGI and was continued on intubation. During the intubation, they were noticed that there was some pulmonary hemorrhage following intubation. Baby did require a little bit of started on nitric oxide in LGI. Baby ER was then screened for sepsis because of these risk factors and continuous high oxygen requirement and pulmonary. I can show you the first X-ray of the baby. This was done around 4 hours of life. As you can see, EDG tube is around just close to the clavicles. NG tube is not completely into the stomach, but it's down. And you can see there is some changes in the left lower lobe. And it also reported that there is a mild pleural effusions on both sides and more patchy changes across both sides. So it was initially started on our empirical antibiotics, benzyl penicillin and gentamicin. X-ray was suggestive of congenital pneumonia. And on arrival in the specialized neonatal care unit in LGI, umbilical lines were inserted and secured. Then show the next X-ray. So this is the next X-ray. It's obviously it's an artifact from the probe, temperature probe. You can see more diffuse changes on both sides. The umbilical lines were secured, but UVC was later on taken out because of the suboptimal position and replaced with the PICC line. Baby also started on some milrinone and adrenaline because in the view of the low blood pressures, which were slowly weaned off in next couple of days. It was continued on IV antibiotics. Baby ER also had an echo done on the second day of life, which showed suggestive of pulmonary hypertension. Was started on hydrocortisone and a short period of high frequency ventilation, which did not help much. And later on also received an infusion of magnesium sulfate, which helped with oxygen. She was sedated on ventilator and later on in next few days was extubated and started maintaining saturations on low flow oxygens. During the whole course of event, there was a glucose level, her blood glucose level was also a bit raised, which was managed with insulin and initially which normalized later on after 24 hours. Baby also received half correction dose of bicarb. Initially, there was metabolic acidosis, but it also resolved later on. Around day 7 of life, the baby was extubated and started maintaining on low flow oxygen. Um, Started on some initially on parenteral nutrition and now started on trophic feeds, which was gradually increased and built up. Uh, During the course of illness, started spiking temperatures again and had another septic screen done. Uh, Another septic screen done, and baby was started on second line antibiotics, teicoplanin and gentamicin for the complete 14 days. The blood cultures for the baby was negative. Uh, in, Full blood count initially shows a white cell count of 24,000 with neutrophils of 14.4, hemoglobin of 177, and platelets of 299 with a hematocrit of 0.534. Initial CRP was less than 1, and then repeat one was 7.7. Chest X-ray that we just saw shows a patchy consolidation in the left lower lobe. So we completed a course of 14 days of IV gentamicin and teicoplanin based on the local guidelines. Because the baby was continuously spiking temperatures later on as well, and there was temperature instability and increased oxygen requirement, and was discharged after that. The viral panel was also done, which was negative for the baby, and then the baby was discharged on 28th of December on breastfeeding, and observation wise was completely normal. So this was initially congenital pneumonia, which was further aggravated by a PPHN. There is follow-ups booked with neonatal cardiac clinic and audiology, hip hearing screening, and hip ultrasound because of the breech presentation, because of the risk factors. And then there is a pediatric follow-up also booked for the baby. So key learning points: PPHN can complicate term deliveries, and multidisciplinary and ICU care is essential, and good recoveries with timely escalation and proper management of the respiratory airway.
Great. Thank you, Raza. Just a request from me, actually. Many of us here in Uganda are not used to seeing chest X-rays. We have limited access. I just wonder if you might take us back to the maybe the first chest X-ray you've got. Just talk through, particularly you mentioned the position of the ET tube, the NG tube. I think that would be really interesting for those on the call. And then if anyone has any questions, kindly pop them in the chat. Go ahead, Raza.
So this is the first X-ray that we got for the baby. As you can see, there is an ETT tube. This one that goes right in up to the clavicle point here, and this one is an NG tube. It's going all the way down. It hasn't reached the stomach yet. It's so after this X-ray, obviously we extended it across. You can see this stomach bubble uh, right at the bottom. So obviously this needs to be an extended across here. This X-ray was reported as some patchy changes on left lower lobe around here, just behind the heart, and was also reported to have some mild pleural effusions on both sides. Here, the radiologist who reported the X-ray also reported some patchy changes across both lung parenchyma on both sides. Whereas this X-ray, obviously the tube is, the ETT tube is a little bit extended on around here, adjusted on the second rib, around the second rib here. This is an NG tube, just going all the way down. This X-ray is, you can see more patchy changes, but the consolidation is more visible around here.
Sorry, Raza, there's two questions in the chat. One is about how was PPHN diagnosed, and Kath has responded on echo. I just wondered if you might share the features that we look for in echo for PPHN. And then the second question is, why did we choose teicoplanin in this case, as opposed, it would be an unusual choice here in Uganda, is maybe why that question is there. So maybe you can explain why in your setting teicoplanin is your second line antibiotic.
Yeah, the antibody, I think it's more based on the local guidelines. Uh, if you get any sensitivities in the blood culture or in the tracheal aspirate, obviously the uh, and choice of antibiotics is based on that. But if obviously the baby was spiking temperatures and there was a temperature instability, uh, that might be the reason to going on the second line of antibiotics, diclofenac and gentamicin, based on the clinical picture that we were seeing at that time. And regarding the echo findings for PPHN, obviously I can see that Dr. Harrison has mentioned. So high pulmonary pressure, more than systemic pressures are indicated of PPHN.
Great. Yeah, maybe to add the other things, we might see pulmonary regurgitation. And if you've got the PFO open, you'll see a right to left shunt across there. And again, if you've got a PDA, I think Immaculate was asking the question, you can see right to left shunting as well across that PDA. That's great, Raza. So I would love to once again introduce Dr. Florence, Dr. Moris, who have joined us from Lira Regional Referral Hospital. And I would like to invite them to share with us their presentation.
I'm Dr. Moris, Sekituku, a junior house officer in Lira Regional. And with me, I have the objectives once again. The first one is to recognize neonatal pneumonia clinically without reliance on investigations. The second is to assess the severity of neonatal pneumonia using standardized respiratory scoring systems, as we shall see later on. The third is to outline the principles of management of neonatal pneumonia in a resource-limited setting. So this presentation is, we had a baby of AF who was a 2-day-old male who presented to the NICU, the neonatal intensive care unit, with difficulty in breathing that had been on for 1 day. Baby was born at 35 weeks, 6 days, and presented with a 1-day history of difficulty in breathing. However, there was no associated cough. There was no history of Lewis discoloration of the body. The mother reported a history of fever, and this was associated with a refusal to breastfeed. So the prenatal, the perinatal, and postnatal history. The mother reported to have attended antenatal clinic 6 times and was booked at 5 weeks. She had routine care, and she reported an uneventful pregnancy, and also reported that she was screened for HIV and syphilis, which were negative. The baby was born by spontaneous vaginal delivery, cried immediately, and was not resuscitated, and also weighed 1,008 after birth, and also was immunized with the BCG vaccine, polio 0, and the hepatitis B vaccine. So on admission, when we did the examination of the baby, the admission vitals, the saturation, oxygen saturation was 77 on room air. The heart rate was 162, which was elevated. The respiratory rate was 72, which was tachypnic. And the temperature was 38.2 degrees Celsius, which was also elevated. So on examination of the respiratory system, we noted that the baby had nasal flaring, grunting, with severe chest indrawing. And we assessed and found that the Silverman-Anderson score was 6, which was moderate respiratory distress. On auscultation, there was equal air entry bilaterally with a clear chest. When we examined the abdomen, it was of normal fullness, was soft, moving with respiration, and there were no palpable masses or organomegalies on examination. The cardiovascular system, the peripheries were warm with a capillary fill time of less than 3 seconds. Heart sounds 1 and 2 are normal, and we had no added sounds. The central nervous system examination, we noted the baby was very lethargic, but with a normotensive fontanelle, and had normal primitive reflexes, which were the grasp, the suckling, and the plantar. Even the moral was okay. And the baby had normal muscle tone. So our working impression was neonatal pneumonia. So in our management plan, we started the baby on oxygen by CPAP, and we initiated empirical antibiotics, which is IV ampiclox at a dose of 180 milligrams, 12 hourly, IV gentamicin at a dose of 9 milligrams once daily, and then we exposed the baby to lower the temperature. The total fluid requirement on day 2 for this baby was 80 mils per kilogram a day, and of which express breast milk was 7 mils every 3 hours through a nasogastric tube, and then IV dextrose 10%, 11 mils 3 hourly. Then we're supposed to monitor the vitals of this baby. I want to report, we received this baby about five days ago. I want to report that the baby is shown significant improvement. We weaned the baby off CPAP, and currently they're on free flow oxygen at 0.5 liters per minute. The baby is able to breastfeed and is more active. I think tomorrow we shall be able to assess and put them off oxygen, and we consider discharging them later on. Thank you, and I would like to invite my senior to take us through the next part of the presentation.
Yeah, thank you so much, Moris, for presenting the case. And to all of us on the call, remember, our task was to recognize signs and symptoms of pneumonia without investigations. So we limited ourselves to knowing this in resource-limited areas. So, and that is what we focused most in our presentation. So in the overview, neonatal pneumonia remains a major cause of morbidity and mortality worldwide. And the neonatal pneumonia mortality risks is strongly dependent on the birth weight and the age. So the smaller the newborns are, like their preterms, the higher the risks of them developing pneumonia. And even the age, the younger they are, the higher the risks, which we shall appreciate when we get into the types or the subtypes of the pneumonias. And the diagnosis of the newborn pneumonia remains very challenging, especially in resource-limited areas, as the presentation of severe pneumonia or neonatal pneumonia is similar to what we see in the newborn sepsis. And even so, access to blood cultures are limited and very unaffordable to many of the centers. Even so, the blood cultures have a low sensitivity in the neonates. So, as for the magnitude of neonatal pneumonia, there is scanty data, especially in Africa and even in Uganda. The only data that I used to appreciate the organisms and the sensitivity panel was that of 2020. It was on neonatal sepsis study at Mulago National Referral Hospital in Uganda by Tumwine and et al. This was a cross-sectional study to determine the proportion of newborn with symptoms and signs of sepsis who had positive culture, bacterial etiology, and the antimicrobial resistance. 359 neonates were recruited, and out of the recruited newborns, isolates of Staphylococcus aureus, up to 63% were isolated. E. coli, up to 15% were isolated, and Klebsiella pneumoniae accounted for 10.9%. And indeed, when we look at these organisms, they are the very same organisms that are evicted in the neonatal pneumonia cases. So, in low-resource settings, diagnosis of neonatal pneumonia remains challenging for reasons I've said, and early recognition and antibiotic initiation, in this case, empirical, will save life. And we base majorly on clinical presentation of the baby and supportive care, like administration of oxygen, like it was in the case presented, the fluids, breast milk expressed equally are important, just like the antibiotics are. So the subtypes of neonatal pneumonia that we see commonly in practice, we have the congenital pneumonia, which causative organisms are those acquired during the intrauterine life or during the birth process. And many of the organisms are the group B, streptococci, the Staph aureus, Klebsiella species, Herpes simplex virus, rubella, amongst other organisms. In the late onset pneumonia, these are acquired majorly from community because some of the babies will have already been discharged home, and those that occur within the hospital are those that were exposed to aseptic environment and aseptic procedures. And commonly, the organisms that are isolated from those with late onset pneumonia, these were commonly the gram-negative organisms like the E. coli, Klebsiella, Acinetobacter, and Pseudomonas. A gram-positive like Staph aureus still remained common. So when confronted with a newborn, it is important to subject questions that are focused so you can easily rely on them to come up with the possible causative organisms. So the onset, if it is below 72 hours, that helps us to identify and restrict ourselves to the organisms acquired during the utero and those acquired in the birth process, and those that will present with symptoms over 72 hours guide us to know whether they are nosocomial or community-acquired infections. Mothers with prolonged rupture of membranes, that is beyond 18 hours, are risks. Mothers with fever, the foul-smelling liquor, prematurity, low birth weight are risks, and those who were born through meconium-stained liquor, as meconium can lead to aspiration syndrome, worsening the presentation of these babies. And the place of delivery matters, whether they were home deliveries, they were greatly exposed, and those delivered within the facility, they have reduced risks of acquisition of those organisms. So, in the diagnosis of neonatal pneumonia, we have guidelines in Uganda at lower facilities like health centers, 4-level, and at times the general district hospitals. They use the integrated management of newborn and child approaches, and we are guided by the presentations we see here, like fast breathing, beyond 60 breaths per minute, the chest-in drawings, which includes also the stenoreception a baby may grant. They may have stridor, or they may appear to have central cyanosis. Apnea is one, and poor feeding or inability to suckle could be a presenting symptom, and they may also have temperature instability. The baby may appear lethargic or have altered level of consciousness. What guides us to grade the severity of the respiratory distress, like at Lira Regional Referral Hospital, we use the Silverman-Anderson score, which we rely on the 5 parameters to score the baby. And the parameters are the upper chest, lower chest retractions, xiphoid retractions, the nares dilatation, or what we call nasal flaring, and the expiratory grunt. So like for our case, the presented one, when we administered this Silverman-Anderson score, we were able to score baby at 6, which guided us to initiate baby to CPAP. So for each of those parameters above, if none of them is present on the baby, the grade is 0. And if, like in the upper chest, if there is lag between the inspiration, you will score the baby as 1. And it becomes grade 2 when there is a seesaw movement. When we take the example of expiratory grunt, if a baby is not grunting, then it is a 0 score. But if you are able to pick the grunt using a stethoscope, that is 1. And if there is marked grunting that you can pick even without a stethoscope, that is a score of 2. At the end of it, you add up the scores from these parameters, and this guides on which intervention to start the baby on. If the score is 0, the baby does not have a respiratory distress. And if the score is 1 to 3, that is a mild respiratory distress, meaning the baby can be left on free flow oxygen. But like in our case, where the score was 6, between 4 to 6, that is moderate, and it requires a CPAP, while 7 to 10, that is severe forms of respiratory distress, which may call for a referral for those who don't have artificial ventilators. For the down score, it is equally administered in the same way, but the parameters here for the assessment, what we didn't have the other side of Silverman's Anderson, is the respiratory rate, the cyanosis, and the hair entry. But the assessment is done the same way. A deeper dive into the revision about this automatically displays that Down's score is the most appropriate tool to be used in assessment of respiratory distress, while the Silverman-Anderson score works best in measuring or assessing the hypoxia level. So the treatments in Uganda and in especially resource-limited areas, we observe the protocols which every facility has. So we start the babies empirically on first-line antibiotics, which are ampicillin and gentamicin. However, we are aware about the resistance. So in areas where they can do culture and sensitivity, they still generate a local antibiogram. Like for Lira, ampicillin actually is known to be resistant to most of, the organisms that are isolated in newborn sepsis and the neonatal pneumonia. They are resistant to ampicillin up to about 83%. That's why you had Moris talked of the drug we gave were ampiclox together with gentamicin. So for the late onset neonatal pneumonias, the first line antibiotics, we have the cloxacillin plus gentamicin. Again here, we are mindful about the sensitivity to the isolated organisms as guided by our antibiogram. Tentatively, we can also give cefotaxime if it is available, but in most cases, this is limited and mothers do procure them. If the baby is not jaundice and they are not extremely having low birth weight, then ceftriaxone can also be used, but it must really be used cautiously, especially if the babies have jaundice, then they shouldn't be a drug of choice for them to avoid bilirubin encephalopathy, which poses a great danger to the babies. Other than the antibiotics, supportive care are equally important. And here for our baby, we administered oxygen by CPAP. And as we had Moris said, there is marked improvement. Enteral feeding by NGT for those babies with weak suckling reflexes. And for those without suckling reflexes, IV fluids, especially in severe respiratory distress, for fear of compromising with the diaphragm and also regurgitation of feeds. Temperature control is a good supportive care. If they become hypothermic, we put them onto under the radiant warmers, and if the available warmers are occupied, still we advise to put the babies on warm cloth. And monitoring of the urine output is still very important. So this was our baby, the one we clapped. We are all able to appreciate the subcostary session and the lethargy that is displayed by the baby. While the baby is on treatment, it's quite important to monitor the vital parameters like the respiratory rate. The clinical score is continually administered to help us appreciate the improvement, oxygen saturations, feeding tolerance, and temperature, the other parameters that are monitored during the care. And if there is no improvement to this baby between 48 hours to 72 hours, it's good to review the diagnosis. It could be other conditions, not really necessarily the neonatal pneumonia. Assessments to adherence to dosing. This we can easily do every day as we review our babies, and also considering alternative diagnosis like probably the respiratory distress syndrome due to surfactant deficiency, also whether the meconium aspiration syndrome occurred or a congenital heart disease. So after that, those are ruled out. A change to second-line antibiotics is usually required, and where possible, a blood culture to look for resistance in this case. However, Lira, we don't yet administer lung ultrasound in the diagnosis of neonatal pneumonia, but it is one thing we can easily venture into because of the benefits that it has over the chest X-ray. So lung ultrasound is an accurate, reliable, quick, easy to use, and real-time, low cost, and moreover, radiation-free imaging modality. Its application in neonatology now has been taken up by many centers, even in Uganda, and it offers early bedside use without necessarily having to move the baby to the radiology when the babies are on like CPAP. And it also demonstrates features highly suggestive of pneumonia, which makes it really a good modality for intervention, which features you are looking for consolidations, bronchograms, pleural effusion, or the presence of the B lines. And it also offers differentiation from other causes of pneumonia once administered. Reduction in radiation exposure is the most appreciated role, which easily offers everyone a safer serial assessment using the ultrasound. So our take-home message for this presentation is to have a brief but focused history once confronted with a baby. Use the Downs or SAS score to assess level of severity of respiratory distress. Treat empirically and treat early instead of waiting for culture reports. Supportive care equally important, like antibiotics, and clinical evaluations are what we employ much. Thank you so much for listening.
Thank you too, Moris and Florence. Beautiful presentation, very clear and really highlighting some of the challenges that many of us on this call face on a daily basis, making those diagnoses. Maybe just to add on the end, lung ultrasound is really a great tool that is available to us, as Florence has alluded to. It can be done at the bedside very easily for us in this setting. Can help us exclude as well. I put in the chat, but a pneumothorax is something that's possibly a little bit tricky to diagnose, but really helps us to look for that. Pleural effusions, you said, RDS, pneumonia. So I think it's something that all of us should strive to learn that skill and bring it to our neonatal units here in Uganda. Lots of the questions. Thank you to Dr. Kath for answering them. I'm just going to perhaps pick a couple of them. Many people appreciating in the chat the clear and beautiful presentation. Question about how many days to receive IV fluids. Just to share that with everybody. IV fluids are there. They're not great. IV fluids don't give any nutrition. There's two answers in there. Ideally, get these babies onto milk as soon as possible. We can share once again the Ugandan national guidelines for newborn care on the mailing list, Jeanette, so people have got those. And we're getting down here. Every presentation here inspires me to become a neonatologist. Great, because we need more neonatologists in Uganda, so we keep giving more presentations. Anybody have any other questions, please, or appreciation? Please go ahead and put them in the chat. I just had a question for you, Florence. Here in Mbali, we prefer to use the down score, and actually that's what we use here and have done for many years. You said you use the SAS score, but you said when you looked at the literature that the down score was better. I just wonder if you've used both, and maybe you might share your experience and why you chose to use the SAS score.
I don't have really much reason to say why we decided to use the SAS score, but I think it's what I found on ground and I just adopted it. It is just this time that I was preparing for the presentation that I had to read deeper to appreciate. But following what I got in the literature, I think we are going to take up on the down score and see how easily we are going to appreciate it over the SAS score. Thank you.
Thanks, Florence. Maybe just to add, then you really eloquently described the cutoffs of 0 to 3, 4 to 7, and then 8 and above. Just for anybody who, so people don't get confused, the cutoffs are the same with the two scores. So anybody of 4 or more should ideally be on CPAP, as with the case from Lira, and anybody of 7, 8 or more is severe and needs a bit more of an intervention.
The frequently found bacterial organisms include, in the UK, it's most common in early onset pneumonia, is a group B streptococcus, and then Staph aureus, E. coli, Klebsiella, Enterobacter, and Enterococcus. With late onsets, it's E. coli, Listeria, Staph epidermidis, Pseudomonas aeruginosa. And if there is some acquired postnatal pneumonias in nurse neonatal units with RSV, adenovirus, and parainfluenza with Staph aureus gram-negative organisms, and transmission can happen via staff, parents, and obviously with the equipments with prolonged stay in the neonatal unit. As clinical manifestations are quite described in detail with the previous presentation, they are quite subtle and non-specific presentation. You can see some temperature instability, poor feeding, lethargy, signs of respiratory distress. In severe cases, we can see some apnea, shock also. Radiological findings, it's I've shown you a couple of x-rays. It's streaky confluent opacities, peribronchial thickening. In group B strep, you can see the diffuse granularity with shadows across both sides that we saw. There can be a little mild pleural effusions that we saw in the previous x-rays, and abscesses in some pneumatoceles as well. The clinical diagnosis of pneumonia is challenging and may not always be correct, over or underestimated. Early tracheal aspirate cultures can be obtained within the first 8 to 12 hours. That may help in diagnosing, especially in certain clinical conditions. But we have to look at the risk factors, including maternal temperatures and clinically chorioamnionitis or leukopenia. But even a positive blood culture or proven airway colonization do not necessarily correlate with a clinical picture of sepsis or pneumonia. In the clinical, pneumonia is diagnosed based on a combination of perinatal risk factors and signs of neonatal respiratory distress with positive lab studies and radiological signs and a typical clinical course. So despite advances in neonatal medicine, pneumonia remains a serious problem even in the developed countries, mainly due to the increased survival of very preterm births and their susceptibility to early and late bacterial infections. The clinical spectrum of pneumonia is complex. Symptoms are often non-specific, and lab findings may be of limited value, making a rapid and a correct diagnosis difficult. And treatment can also be challenging based on the multi-drug resistant bacterial pneumonias. So early diagnosis, we start from the maternal history. Obviously, it gives us some clues. Then we look for the gestational age of the babies. In very preterm babies, obviously our differentials include RDS, and if there is some meconium aspiration, we can also rule out that. Radiology and microbiology can guide us in managing, but obviously it's more of the clinical picture about the respiratory distress and initially managing the baby with antibiotics and supporting the respiratory airway. And there is a high mortality if untreated. Thank you.
Great, thanks very much, Raza. That's really great. A beautiful presentation. And I think I would like to extend a huge vote of thanks to Raza, Florence, and Moris, who have all given us beautiful, clear, interesting presentations today. Lots of things to learn, lots of things to take home. On my side, I want to encourage people really to focus on the supportive care. Some of our pneumonias, as you have heard today, are not even bacterial, so your antibiotics are not even doing anything. But the supportive management that came up, I think, in some of the early slides from Moris is just as important. And we saw their baby there on CPAP. Ministry of Health in Uganda is trying really hard to send around via bubble CPAPs. Other people, I think, have got Diamedica or Fisher and Paykel, but let's really focus on using the Down score, the SAS score that Dr. Florence has described to us. And if we're seeing those high respiratory scores, trying to use CPAP for our babies. It will really save lives. It takes a little bit of time to learn, but let's get them off the shelf if they are still on the shelf in our facilities, and let's get using them and really provide the respiratory support that these babies need. I can see there's a question in the chat about how to make fluids. I have actually shared a little bit higher up in the chat, and maybe Jeanette, you'd kindly send that out to the email list. But the Uganda National Protocols for Care of the Small and Sick Newborn have got a lot of those details in there about fluids and how to mix them. And maybe at some point we need to think about having a clinical grand round that focuses perhaps on nutritional and fluid support for infants. Kath has said respiratory scores help assess objective response to treatments and very helpful. Thank you for that reminder, Kath. I think it's not just about doing the Down score or the Silverman-Anderson on admission, but using it regularly every 4 hours, twice a day, every day, as often as you can use those scores. It will really help you tell whether your baby is getting better or worse. It's also really helpful in communication. If you phone the pediatrician or the neonatologist and you say, I have a baby with a Down score or a Silverman-Anderson score of 6 or 7, they will wake up and come and help you. If they say it's 2 or 3, they're not going to come and help you. So it really helps to communicate when we don't have access to things like x-rays or blood gases to share with seniors. It helps to communicate with one another and up to senior level how sick that baby is, and allows us also to monitor the response to our treatment. So excellent. So I think the last thing then that we wanted to share with you today, we held the Scale Neonatology grand rounds every 2 months. So we've got 5 planned over the course of 2026. Our next one is scheduled for 12 midday UK, 2 p.m., 2 in the afternoon for us here on East African time on Friday, the 10th of April. And we'll be looking at the long-term follow-up of high-risk babies. So those who've maybe been born, had meningitis, premature, HIE, those kind of things. So really excited to see as many of you there as possible in April. And Jeanette will love to take a photo of everybody in a second. So in a moment, before you drop off, I will ask you all just to turn on your cameras so that we can take a photo of everybody who has attended today. And lastly, yeah, huge appreciation once again to our 3 presenters. Otherwise, enjoy the rest of your Friday and your weekend, and we would love to see your faces.